This is Dr. Jamal, and welcome to Teaching Rounds for third and fourth year medical students, PA students, and nursing students. The first case is on anaphylaxis. A 20-year-old woman is brought to the emergency department by an ambulance after collapsing at home. She's been seen by a regular doctor earlier in the day and prescribed penicillin for bacterial pharyngitis. Paramedics report her field vitals were remarkable for a blood pressure of 70 over 30 millimeters of mercury, a heart rate of 140 beats per minute, and a respiratory rate of 40 breaths per minute. And her oxygen saturation was 76%. Intravenous fluids and oxygen were administered during transport. Paramedics are assisting the patient's breathing with bag valve mask ventilation, and her oxygen saturations remain low. On physical examination, the patient is obtunded with perioral cyanosis, tongue swelling, stridor, wheezing, and labored breathing. Her skin is cool and clammy with large urticarial lesions. What are the next steps? What treatments should be instituted?
So in making the diagnosis of anaphylaxis, you really need to combine the history of the exposure to the offending agent and the clinical characteristics. The clinical characteristics involve three organ systems: the respiratory, the skin, the cardiovascular systems. When you look at the respiratory, it affects primarily the upper airways, and the patient presents with an upper airway obstruction and stridor. The skin exam, the patient will have evidence of a type 1 allergic reaction where they'll develop a rash, urticaria, and pruritus. In this patient that we presented, the patient had large urticarial lesions. In the cardiovascular system, the patient presents with hypotension and tachycardia. It's this constellation of three characteristics that occur after the exposure that make the diagnosis more certain. The treatment is, of course, this is a medical emergency. What's happened to this patient is life-threatening, and treatment needs to be instituted immediately. The diagnosis needs to be entertained immediately, and the treatment is as follows. The first is to put the patient in a recumbent position, and then to administer epinephrine. Epinephrine is administered in a 0.3 to 0.5 mils of a concentration of 1 in 1,000 in the anterolateral thigh and repeated every 5 to 15 minutes. This can be done 2 or 3 times, and what needs to be noted is that even if the patient responds initially, the patient may then have a delayed allergic reaction minutes to hours later. If a patient is felt to be safe enough to be discharged, they need to be monitored for at least 4 hours in the emergency room. But of course, in this case where the patient presented in frank shock, she would have warranted an admission to the hospital, and I would say even if she rebounded perfectly with normal vitals and felt well and had no significant ongoing symptoms, she would have stayed in the intermediate care unit. Other medications that should be given should be Benadryl 50 to 100 milligrams IV, Solumedrol 125 milligrams IV, and albuterol per nebulizer. Albuterol can be given as many times as necessary. Sometimes racemic epinephrine is used, and that should be considered as well. Oxygen, of course, is mandatory in this particular case because the patient was hypoxemic and in respiratory distress. She was already being bag valve masked, and really in this case, if she did not rebound quickly with epinephrine, preparation should be made for intubation and cricothyrotomy. When that decision is made to proceed to a cricothyrotomy, one should consult general anesthesia and general surgery and request their presence if that's at all possible. Again, when people have succumbed to an anaphylactic reaction and have died from an upper airway obstruction and a cricothyrotomy was performed, when you look at those case reports and look at what could have been done differently, what is over and over the case is that the decision for cricothyrotomy was done a little late. This should be done earlier rather than later. Other management decisions should be as follows. The patient should be educated about the severity of the reaction that they had. Allergy testing should be requested. And lastly, if and when the patient is discharged from the hospital, an auto-injectable epinephrine prescription be given to the patient.
Let's go over the case that we initially presented and what really the take-home message should be about this. This patient presented with an extremis in cardiopulmonary collapse, essentially. And the big take-home message here is how important epinephrine is and how it should have been administered. Immediately, it should have been given. It should have been given by the EMS, which it wasn't. It should be given immediately when the patient presents to the emergency room, and first IM, and then, as you could tell, to the extent that this patient had the problem, it should be mixed intravenously and given that way. The other big point is about the respiratory status in this patient. The patient was cyanotic, the tongue was swollen, and they had labored breathing. Securing the upper airway was of paramount importance in this patient and should not be delayed. And it should be done by the most experienced people, and not only in the emergency room but really in the hospital. So it is very important to ask for help and not to think that you can do this yourself. If you can get anesthesia there, to use anesthesia. If you can get even a general surgeon there, get a general surgeon there. Get a cric tray there. Get several different ways, and just be prepared for the worst, because that's really the single most important thing about this is the dose of epinephrine, how it should be administered, and then securing the upper airway, which should be done immediately.
Again, thank you very much. This is Dr. Karim Jamal, and remember, you see what you look for and you recognize what you know.